welcome to episode 70 of the Let's Talk Thyroid podcast. Today I'm chatting with General Practitioner Dr Anna Ord, all about how to understand your own blood tests. Now, I don't know about you, but it's taken me a long time to be able to look at my blood tests and make sense of them, or try to make sense of them. Understanding our own thyroid blood tests can be complicated. We've got to understand what the tests are, whether there was the full array of tests that probably should be ordered in a thyroid test has been ordered. What's the difference between optimal range and normal range? What happens if you're in range but you still feel hypothyroid symptoms? These are all the questions that I'm exploring with Dr. Ord today. Let me tell you a little bit more about her and we'll dive right into the episode. So Dr. Anna Ord is a general practitioner. She is from Poland. She did her specialty training in the United Kingdom, but she's been living in Perth, Australia since 2017. She was actually diagnosed with Hashimoto's 4 years ago, and that helped her to really look at managing thyroid health as a doctor from a very different perspective. She started to do a whole lot of reading and research. She did additional training with the Australian College of Nutritional and Environmental Medicine so she could be better equipped to help her patients and herself manage her thyroid autoimmune condition on that day-to-day basis. So she's really upskilled her medical practice, and she, I think it's really helped her to understand how to treat thyroid conditions in a way that isn't normally taught in medical school. So sit back, enjoy. You might want to actually pull out your last couple of blood tests and look at the numbers as she's talking and explaining them. That might actually just be a really helpful, practical thing you can do to cement in the knowledge that she's sharing and how that pertains to you. So hope you really enjoy. Well, welcome Dr. Anna Ord to the Let's Talk Thyroid podcast. This is fun to have I know you're based in Australia, person on the podcast, and all the way from Western Australia. So welcome.
Oh, thank you so much. Thank you so much for having me, Annabelle. It's a real pleasure.
Yeah, it's going to be fun. We've had a bit of a chat last week. So we're going to be diving all into helping people understand their thyroid blood tests, because you are a doctor. And I think it's a really common question that people ask. We're not really very good at understanding what tests to ask for, or then how to interpret them, read them, what to do with them. So that's what we're really going to dive into. But first, I'm just wondering, can you just explain a little bit about, who you are, what you do, and, what's led you to be interested in thyroid health?
Mm-hmm. Okay, so my name is Anna Ord, as you've kindly introduced me. I'm a general practitioner with just over 10 years experience as a GP, graduated in Poland all the way back in 2006. Moved over to UK, did my internship and my specialty training in general practice, and worked full-time. Moved over to Australia in 2017 and still working full-time as a general practitioner. In terms of what made me look more into the thyroid conditions, especially Hashimoto's thyroiditis, is, as it usually is, my personal journey. So that all started probably about 4.5-5 years ago, when I got diagnosed with Hashimoto's thyroiditis, and that sort of sparked my interest to looking into much more deeper in what we taught in medical school, or during the GP training. So that was that.
Yeah, as it often is, isn't it? It's our personal issues that cause us to dive deep in, because I guess as a general practitioner, you've got to be across a very broad range of health issues, so whatever walks in your door could be all sorts of different things. So you've got to know a little bit about a whole lot of things. Is that right?
Very, very right. That's correct, yeah.
Yeah. Which maybe does that, we'll cover this a little bit, but is that why often as typical thyroid patients going to see their kind of typical general practitioner can get a bit stuck, because that practitioner is kind of good at a broad range of things but maybe doesn't know a whole lot about thyroid health. Would that be fair?
I think so. And, when you have in mind what is actually taught in medical school or, during the GP training is very much, all right, so your thyroid is underactive, you need some thyroxine, there's your thyroxine, off you go. Or your thyroid is overactive, well, that's a bit more complex, you've got to see an endocrinologist, off you go. So that's what we're told. That's pretty much how I started with myself when I got into when I got first diagnosed. So that was my approach to myself, which is very different to what I do now. So it was definitely a journey, and I'm hoping, and I know that my patients have benefited from me gaining that extra knowledge.
Yeah, I'll bet.
Yeah.
Yeah, so do you mind me asking a couple of questions about your thyroid story first before we kind of really dive into the meat? Because I think it does give some context to you and your experience as a doctor, and it gives you that extra depth of what am I looking for? Well, I guess compassion would be one thing, but, actually ability to treat your thyroid patients well. And I'm sure you have you're in a general practice still, aren't you? You're not just treating thyroid patients.
Everything.
Yeah. So what made you think you might have had a thyroid problem in the first place? How did that play out for you?
So basically, about 5 years ago, what I've noticed was something, I guess, a bit less usual, and I don't really hear that very often from my patients, is that I had this ache in my actual thyroid. You don't hear about it very much in terms. It's not a typical Hashimoto's thing, and I knew that this was an area of my thyroid, so I had a little prod to make sure that there was no major lumps, and I haven't discovered anything. So I decided to get some basic bloods done, and there it was my basic thyroid functions, and they came back perfectly normal. So
yep.
Yes, so to which I tried to convince myself, well, look, this is not your thyroid, exactly as I would say to my patient, look, it's not thyroid.
Well, you were following what you were taught to do.
But then it was still happening, and it would come and go. It was just a strange sensation. So I decided, well, maybe I should look into it in a little bit more of a detailed way. So I got some antibodies done, and there they were. They were sky high. So that's how it started. And I wish I could say that from day one, I'm like, right, yes, I'm straight onto it. It didn't happen that way. And it took me some time to sort of look into, where can I get any more information? Because if I followed my, what I was told in medical school, it would be like, well, nothing much you can do. You can just sit and wait. And then when your thyroid is actually under functioning, then we stick you on some thyroxine, and that's pretty much it. And I didn't like the idea of that. So I decided to, broaden my knowledge in this subject. And
so you sort of did what the typical thyroid patient does is, well, hold on, or I've done what the doctor said and I'm not feeling better, or maybe you even knew preemptively, well, my thyroid function's still okay, but I know the thyroid antibodies are not. What else can I do? So where did you go?
So I basically had a look at the extra training for doctors, for medical professionals, and that's how I discovered ACNEM, which is the Australasian College of the Nutritional and Environmental Medicine. And they had all sorts of different courses. One of them was the thyroid one, but I had to do all the sort of foundational training, and it was a mind-blowing experience. And I feel like when you discovered all that stuff, you just cannot go back. It's not possible.
You can't unknow.
Absolutely. So it certainly affected my day-to-day practice in not just thyroid patients, but anything else that's there that I deal with.
Yeah. So you went looking for what other medical training can I do as a doctor to understand my thyroid and how to treat thyroid health better?
That's correct, yes.
Yeah, right. So well, which I guess makes sense as a doctor to go looking for that, whereas, as the standard patient, we just go Googling and get lost in a sea of internet, some good, some bad, and begin wading through that. So that course, tell us a little bit more about that training.
So it's an interesting thing because obviously I was very, very much mainstream doctor, as mentioned before. For example, moving to Australia and discovering that you've got, for example, naturopaths. I wasn't familiar with this concept, so I wasn't really sure what was all that about. And a lot of, for example, training for at academic is delivered by experienced naturopaths, and so that was definitely an eye-opener and very interesting experience. And I feel like they've got all the knowledge that we don't necessarily come across, during our training. So it wasn't just sort of medical doctors that were delivering the training, but you get people who have the expertise in the natural.
Right. Maybe taking that more whole body, holistic approach. Yeah. So are there no naturopaths in Poland?
You see, I never worked in Poland as a doctor, but...
Oh, so you did your training there, but then did the rest in the UK. Yeah. And does the UK not have naturopaths?
No, it's not something that people, it's a common thing in Australia. You don't get your answers from your GP, so you go to naturopath and hope that they will look a bit more holistically. And no, it was a new concept for me altogether. Yeah. And I have to say, I was a bit skeptical at first, thinking, what do they know?
Yeah, well, that's I would expect that's a common reaction. It actually, the podcast that's just out at the moment came out this week. I interviewed a lady in the UK actually, and I think she's a nutritionist, so not a naturopath, but I suspect there's some overlap. And I think as I talk to people from all around the world, or mostly UK, America, Australia, some of the sort of terminology of qualifications, they're not all interchangeable. I think I'm working out that what we call a naturopath may be called a functional medicine practitioner in the States, and a nutritionist perhaps. I know we have nutritionists here too. So it is interesting in that holistic health space across the world. I'm sure there's a lot of overlap, but they're kind of often called slightly different things.
Yes. But still, very new concept for me. And
yeah. So what did you discover in terms of beyond what you were taught as a general practitioner about how to treat thyroid? What did you discover either worked for you or just works often for other people in terms of managing thyroid health more broadly than just the hormonal replacement?
So to me, the whole game changer was to actually appreciate that it is an autoimmune condition, and there is certain things you can do to affect that, to reduce that sort of inflammation in the body. I didn't go sort of overly drastic in terms of, you hear that people go to extremes in terms of, cutting things out of the diet. In terms of what works for me, and again, it didn't happen overnight. It was more of a process and sort of try and error. First of all, I decided to sort of tackle my ever-increasing weight and decided that, that's a big deal here, and it's a bit of a double-edged sword because not only the thyroid condition makes you gain weight, but then that increased weight affects your hormonal balance as well. So the way I approached it, I started regularly exercise because, over the years I would try and I would fall off the wagon. You get a cold, you get tired, you stop it. And so I decided to just be consistent with it. So what worked for me was to do it first thing in the morning. My little thing is I have a treadmill and I run whilst watching a Netflix show. I choose interesting, inspiring things rather than, daunting or scary things. Something that fuels me, with a positive energy for the day. Mm-hmm. And I stop watching when I stop exercising, and therefore I look forward to whatever happens in the next episode and next thing. And I do it before my family is up, to get it out of the way. I don't even think about it. I don't plan it, apart from maybe having my shoes and my sort of basic outfit ready the night before. So it just happens. It's a habit. I get on and I do it. And that had a massive effect on my general energy level and just obviously weight itself. So that was a major thing, and just creating that habit. It wasn't easy, but it did finally happen for me with just being more and more consistent. So that was my, definitely something that massively changed how I felt. In terms of the diet itself, obviously we know that dairy it does fuel the autoimmunity, can fuel autoimmunity. We're probably the only sort of species that has milk in adulthood. I'm not necessarily very opposed to dairy, and I think everybody should sort of make their own mind about it in terms of how it affects their bodies. But I have reduced greatly my intake of milk. So I swapped the type of milk I would have in my teas and coffees. I'm not really much of a yogurt eater, but I would have a coconut yogurt if I did have yogurt. And I would still have occasional cheese and, still enjoy my bar of chocolate. I do feel like I pay for it because I tend to get more headaches if I overdo on the sort of chocolate side of things. And then you're looking at things like gluten, and I haven't completely cut out gluten. I think it's very important that when you first get diagnosed with autoimmune thyroid condition, that you do get screened for celiac, because there is a big overlap in terms of the autoimmune thyroid conditions and the incidence of celiac antibodies. So I think that's one of the first things.
Yeah, there is a really big overlap, isn't there?
Absolutely. So just to make sure that obviously it's not a yes or no answer. It's a bit of a screening tool, what we have an access to as GPs. But if you not, I guess, listening to your body as well. And for me, the thing was, when I used to just rush first thing in the morning without the exercise and just grabbing a quick piece of toast with marmalade. And the bread would be from supermarket or one of the big chains. I swapped that into I'm lucky enough to have a little bakery on a doorstep, and they really pride themselves into that they do their sourdough properly and
okay, yeah.
And so I would have my slice of rice sourdough with a couple of eggs and some massive big salad in the morning. And I felt that I feel much better off it. Have you ever noticed, actually, Annabelle, when you get the bread from the supermarket, and you try to cut the crust for your child, and you put the two slices together, and you press it against each other, it just turns into dough again. It's not even.
It's like, I know.
We don't. Gluten is one thing, but what other stuff do they add to the bread?
I know. I often think of it. I mean, I know I still buy bread for my family, but I don't eat it at all. I mean, I found a really nice paleo bread that I will have my eggs on for breakfast. But yeah, I know when you get it, it's like glue. I just think of gluten as glue, and I know that's oversimplified, but I just think, who wants to eat glue? And you feel that bread, and you think, ugh. There's very few times now that bread or cakes or biscuits are a real temptation for me. Like, I think it's been a number of years, so I'm talking, I haven't eaten gluten for 10 years, so it's pretty rare that I will look at a piece of bread now and think, oh, I wish I could eat that. A nice sourdough, much more tempting. But yeah, you're right, that supermarket bread, and you think, oh, this is so overprocessed.
So maybe just having less of it, if you really do enjoy it and you feel like it doesn't really affect you in any ways, and you don't have celiac and all that. It's worth considering doing a bit of a trial period without, in terms of, milk and so dairy and gluten. And I guess it's important to mention here in terms of the whole lactose thing, because people sometimes go, oh, well, so I thought I'm feeling unwell because when I have milk, I'm bloated, whatever. And so I decided to swap into a lactose milk, and I'm still not much better. So I know it's not milk. Well, we know it's not lactose, but you still get the dairy protein in your lactose-free milk. So it doesn't really exclude that you do have a problem with milk itself. So yes, so those kind of things, they the sort of basics that you've got to consider at the beginning, I guess, of
Yeah. So making some dietary changes, bringing in some exercise has been helpful for you. I mean, being a doctor is a busy, stressful job, I expect. As managing stress, does that seem to impact your thyroid, like that sort of day-to-day stress? Have you found that?
Massively. And I think what I decided to do, and we obviously know sleep, massively important. You need to have your sleep. But I actually found that being up early in the morning, and still allowing the good number of hours in terms of sleep, but being up early in the morning so I can actually sort of, ease into my day rather than just rush.
Okay, so that gives you a bit of time to set up for the day, even though you're getting up earlier, rather than getting up with the rest of the family and it's just a bit more.
So even
chaos.
those, 5 minutes of meditation a day, I do more than that, but, a starting point is definitely worth considering in terms of the stress management and the considering the effect of the stress on the autoimmunity as such.
Yeah. Yeah, it's something we often end up talking about on this podcast is stress and the impact that has and how do you manage it, and that's a whole other topic. Before we launch into talking about the blood tests, is there anything, that you find you're saying typically to your thyroid patients, like, any sort of top tips or things that you think really, if someone's just listening and they're right at the beginning of their thyroid journey, maybe they've just been diagnosed with hypothyroidism or Hashimoto's, or they're just even still investigating. Is there something that you say to your patients, this is a must do, or really make sure you explore this, or like, is there any sort of top priority?
We sort of covered it now, but I think the main thing is to just make them aware that it is an autoimmune thyroid condition, because, you speak to people who have been diagnosed with underactive thyroid, many years ago, and nobody actually make them aware that the whole culprit of this was an autoimmune condition, and it does help people understand that your bloods may be looking sort of normal on the surface, and you may still be unwell because it's an autoimmune condition. So if you address some of those issues that are fueling the autoimmunity, that's when you may feel better. And, I think it's very similar to sort of managing any other chronic illness, isn't it? Like when you look at the basics, the sleep, the food, that we eat, the stress management, so many different chronic conditions would benefit from those basic changes.
Interrupting for a sec, just to give a shout out to my book, Let's Talk Thyroid, which is hopefully one you are not going to want to lob across the floor because it's too complicated or too heavy. It's really written in a way to be very practical. It's very positive. If you flick through the inside of it, you'll see diagrams and checklists, short paragraphs, lots of really easy to digest information and very practical. It's one you can dip in and dip out of depending on the aspect of thyroid health that you're working on. So you can grab it via Amazon or directly from my website, annabellebateman.com. Got any questions about it, shoot me a message, but hopefully it's one of those books that's going to really help you in a very practical way to start feeling good with your thyroid health. Yeah, I've had a few people with my new book that I've put out, and it's really all about the diet and lifestyle factors that we can do to address the autoimmunity. And I've got a friend in New Zealand who's got MS. She doesn't have thyroid problems, but she's got MS, and she's like, this is exactly what kind of what she already does. She's already on that path, but she said, this just applies to me as well. And, as you say, with chronic health issues, stress, inflammation, so all those things help. But I think that leads probably really nicely into the blood test question, Anna, because so many people don't know that they've got, if they've got an autoimmune component to their thyroid problem. So what blood tests should be being performed to diagnose a thyroid condition?
Okay, so you always start with the TSH, which is the thyroid stimulating hormone. So that's the hormone that's being produced by our brain, by our pituitary gland, that is actually telling the thyroid gland to do its job. Okay, so we're looking at the levels of this hormone, the TSH, and there is a controversy there straight away because the range tends to be quite broad. And for example, in Australia, anything between 0.4 milli international units per liter up to 4 milli international units per liter is considered normal. And I like to look at it and see whether it's in what we call optimal range. And an optimal range for the TSH, I would consider to be somewhere between 1 and 2 milli international unit per liter for a non-pregnant adult person. And if it's outside of that range, I sort of tend to think, well, what's going on? And look how patient presents with that. So definitely TSH, and Medicaid is fairly okay and happy for us to organize this as a Medicare funded test. So if our clinical judgment makes us suspect that this person may have a thyroid condition, we can check the TSH with no problem. Now, it doesn't really give us the full picture of the thyroid health. It only tells us what the brain is producing, and the rest we just have to sort of make up ourselves. So there we have the actual thyroid hormones that we can check as well. And we're looking at the storage form, which is the T4, and then we're looking at the active form, which is the T3. And again, in terms of even checking it, accessing it through Medicare, you're going to have to sort of justify yourself. So if somebody's on thyroid hormones and we're monitoring it, we can check it. But for somebody who we're just screening, there may be a problem organizing straight away TSH and the T3 and T4, because if the TSH is in a normal range, you really have to justify organizing the actual thyroid hormones. And sort of go into more details in terms of the T3 and T4. Again, there is the normal range and then what we would hope for, the sort of more of an optimal range. And then there is the ratio between them that I certainly look at, and that's an important information for me. So, for example, the T4, again, different labs and in different countries may have different reference ranges, but what I sort of normally come across is the T4 between 9 and 19 picomole per liter is considered normal. I would like it normally a little bit tighter, somewhere between 14 and 18 I would be happy with.
So at the top end of that range sort of is more optimal. And can I just ask, when you're talking about T4 and T3, is that well, I know there's there's the free T3 and free, I can never even say it, free T4 and free T3, and then I think is it total T3 and T4?
Yes, the slight problem with the free T3 is that it apparently takes into consideration some of the reverse T3 as well.
Yeah, so that's what I'm saying. When we're asking for, what should we be asking for? Is it just, if you've got someone going to their doctor and say, I want the full thyroid panel, what are they actually asking for? Is it the free or is it the normal or what do you?
You just basically get the sort of total T3 and T4, and that's pretty standard. But you have to sort of again justify yourself to Medicare why you requesting this. And in terms of the levels of the T3 that we're happy with, it's about again looking at the ratio between the T4 and T3 and expecting it to be somewhere in a bracket of sort of 3 to 1. So if, for example, your T4 is 15, you would hope for your T3 to be about 5. So 3 to 1.
Okay.
And that gives us good information in terms of how is this person converting this storage form into the active form. So that's definitely something that we're looking at. And in terms of the sort of autoimmunity itself, what we test for is the antibodies. And in terms of the antibodies, normally you would do it when the other numbers, so the TSH, the T3, T4 would be out of whack. So there would be something abnormal there. And then you would organize the antibodies if you had a clinical suspicion of, for example, Hashimoto's thyroiditis. So in terms of Hashimoto's, the 2 antibodies that we normally test for is the TPO, the thyroid peroxidase antibody. And the thyroid peroxidase is the sort of central enzyme in the thyroid hormone production. And that's a specific antibody for Hashimoto's. Although other autoimmune conditions can have raised TPO as well, but normally you expect it in a sort of smaller number. So even somebody with type 1 diabetes or multiple sclerosis or rheumatoid arthritis can have a positive TPO antibodies. And then you've got your thyroglobulin antibodies, which are less specific in terms of the Hashimoto's, but often they are present in about 50-60% of people with Hashimoto's. You have those. And then if you're having the overactive picture in terms of the TSH, T3 and T4, you may be looking at Graves' disease, which is the overactive thyroid, and then you're looking at the TSI, which is the thyroid stimulating immunoglobulin, which sort of mimics the pituitary hormone, the TSH, and stimulates the thyroid into producing more antibodies. So in a sort of general picture, the classical form, what you expect, and life is always, often not sort of black and white, but what you normally see in an underactive thyroid picture is you've got the raised TSH, so the raised the stimulating hormone that's trying really hard to say to the thyroid, do its job. And then you've got a low T3 and T4. So that's your classical picture. Mm-hmm. Now, in terms of the Hashimoto's, you may have different results at the different stages of your journey. So when you think about when you first have a healthy thyroid gland and then your body starting to producing the antibodies and the white cells that are attacking the thyroid gland, this normal gland is being under attack, is actually often releasing more of the hormones into the bloodstream, and that could be seen as a sort of even overactive stage. And then often you get a period when it sort of all normalizes because it sort of balances itself out, followed by a period of the thyroid being so damaged by those antibodies that is no longer able to produce enough of the hormones, and then we see that as an underactive stage. So in theory, you could be somewhere in that sort of normal range and your antibodies could be there, could be brewing, and that could be happening for years before you even get to the level of your thyroid.
Yeah, before there's been enough damage to the thyroid gland. But then that's the last test that most doctors will test for and won't often test them until everything else is already destroyed.
Exactly right. So in a way, I feel that I was quite lucky in a way that I've tested this before it got to the level of the damage, but then again, I'm not particularly in tune with my body. I certainly wasn't then. So for me to get this sort of, this strange feeling that made me sort of persevere and look into it more was a good thing that happened. But look, I do test for antibodies for people who I feel like there's something going on. I think the whole story, my personal story, just made me more vigilant in terms of, I wonder if this is the case. And especially if there's a family history and the typical sort of symptoms, then are suddenly...
Yeah, it seems to me to be almost in reverse. Like really the screening should be for the antibodies because that's what's causing the destruction. So if you can get that, and I know that this is because the mainstream medical doesn't believe there's anything you can do about the autoimmunity, that they don't do this, but it always seems to me that if there was general screening for the antibodies and you could pick that up first before there's the destruction to the gland and the impact on the thyroid hormones, then that is preventative medicine.
That's right. But, I think the first thing, the number one reason for that is the cost, isn't it? So they've got to draw a line somewhere. And
yeah, so that's when we're talking about, the Australian Medicare covering the cost of that. But if someone can, and I often say to people, and maybe I'm not sure if I'm right in this, you tell me, because I don't deal with Medicare, is can you say, well, look, I understand that Medicare is not going to cover it, but I'm prepared to pay for that test?
Yes, and I cannot see why a doctor would say no to that because, the pressure is off them in terms of...
Yeah, so the Medicare is not going to come after the doctor for saying you're ordering all these unnecessary tests.
Exactly right. So that's what I would suggest that's a possibility, and that's how, for example, naturopaths organize the tests, and it's being organized as a private test. So I would certainly not refuse anyone to organize that.
Yeah, and so I think maybe some of that, and I've talked about it a little bit. I can't remember, but in different episodes over time is just. I think that's the awareness, if you're listening to this and you're having trouble getting the test, just know that really I think wherever you are in the world, you can organise your own tests. You're not just limited by what, say, in Australia Medicare will cover, or in the States maybe your health insurance will cover. You can actually be empowered patient and offer to pay, and obviously that comes out of your own pocket, but I think that's money well spent.
No, absolutely. Potentially, I think if you've got a high enough suspicion, then absolutely. But then the question is, are you going to end up having to interpret your own results because you?
Well, I know that is the problem, isn't it? I know, I understand that. That is the problem. Yep.
Are you going to be told, well, nothing you can do about it anyway? What are you going to do with this?
Yeah. Well, and maybe if you're an empowered patient that knows to ask for those tests, then maybe you're already looking in other places to know that perhaps there are things you can do. I don't know, but you're right, that is a tricky one. So, this is something I often see online is people asking, right, here's my blood tests. What do I make of this? How do I interpret my own blood tests? And obviously you've gone through those tests and what's normal and what's optimal. And I know it's far more complex than that because you've got all the interactions of what's high and what's low and whatever else is going on in other blood tests. But is there, and look, and I guess I would say as a disclaimer, there's nothing like having a doctor who knows what they're doing interpret your thyroid blood test. So this is not about you being able to read and interpret your blood tests in the absence of proper medical advice. But I think it is important for a patient to be able to look at their own blood tests and know what's going on and to see trends perhaps over time. So have you got some tips for how the patient is to look at their blood test results and make sense of them?
Okay, so I'm presuming that everything was done. So you've got your TSH, your T3, your T4, and your
Yeah, so let's just, the full thyroid panel is done. Actually, one other question is, do you normally test for reverse T3?
I don't often test for it because I feel like addressing the stress, which is the treatment for it as such, is a part of the treatment anyway. It's good to maybe test it at the beginning just to see, look, this is what the situation is. This is where it's going. It's going to reverse T3 rather than your active T3. So it can be helpful. But again, I guess the cost element of it is could be quite restrictive. So knowing that the patient will have to cover, I talk about it. I guess not everybody would choose to have it tested. But yes, that certainly could be a part, the part of the full assessment. And so answering your questions, the first thing to do, are we, if we're suspecting the Hashimoto thyroiditis, the first thing you look at, does this person have raised antibodies? And that would be your answer, I guess, to whether they have or don't have the autoimmune thyroid condition. Not taking into account those sort of borderline cases when you've got this, one, not both, but one type of the antibody is very slightly raised. I wouldn't necessarily say, right, you definitely have it. You probably would be a situation when I would monitor you and.
Okay, so if both of them are around that kind of cutoff, you wouldn't automatically assume Hashimoto's. You might think, let's just retest in 6-12 months.
I'm thinking more in terms of, for example, if the thyroglobulin antibodies are raised and the TPO is perfectly normal, and the TPO being more specific for Hashimoto's, I would still make the person aware. And I would still definitely focus on the lifestyle changes, and I would want to have those rechecked just to see which way we're going with those. And so that would be my first thing. Have a look. Do you have those antibodies? I certainly wouldn't be rechecking antibodies every time I check. I monitor somebody's thyroid function test, but it's good to have them checked from time to time just to see which way they are going. And again, we know that they can fluctuate, but generally, if you see that they massively high, and then you do your lifestyle changes and you check them again, and they lower, you are on the right track. I mean, interestingly for me, again, going back to my little ache thing, when I reduced the antibodies by more than a half, that ache disappeared and has never come back since. So, so to me, that was a clear sign of inflammation of my thyroid gland itself. So definitely antibodies.
And you could see that effort that you were putting in, because let's be real, it is effort to make those changes had its impact. And I think that's really important, because when we are making diet and lifestyle changes, it is hard work. And so you want to know that it's working or that it's having an impact. And so that's where, as you say, getting them tested every now and again to see that trend is helpful.
Absolutely, and we know also that it doesn't happen overnight. So people, we want quick results, and and it doesn't often happen that quick. But also, whatever changes you're going to apply, you want to make sure that they are sustainable long term, because that's ideally is what your life is going to be like from now on. So I think anything too drastic, too restrictive, will probably not work well long term. So then, in terms of going back to the results, have a look at what your TSH is doing, and ideally you want it somewhere between 1 and 2. If you're not pregnant and if you're not a child, you want it somewhere between 1 and 2, and that's an optimal range. And then you have a look at your T4 and T3, see if the ratio is somewhere between 3 to 1. So that gives you a good idea whether all the storage form is being converted into the active form, because your body actually wants the active form to be able to do the thyroid's job on the cellular level. So that's sort of the basics of it, what you would want to look at.
So if your T4's too high higher in relation to a lower T3, that's going to impact the ratio, and it might mean then you're not converting it into the T3.
So, for example, a good scenario to sort of think about, for example, if somebody is lacking iodine, and iodine obviously is a frequent topic in terms of thyroid conditions, because one of the basic nutrients required to produce the thyroid hormones. But if you imagine the situation that your body is lacking, when your thyroid is lacking the iodine, what it will try to do, it will try to push the production into of the active form hormone, so the T3, rather than wasting the resources on the storage form, which is the T4. So you will see relatively more of the T3 compared to the T4. So that's an adaptive mechanism. It's not going to serve you forever, because eventually, when you don't have that sort of building block, you're going to run out of those resources. But it tells me, for example, that there could be deficiency in the iodine when the T3 is relatively higher compared to T3. So our bodies are clever, and they're trying to sort of do the best in the circumstances, and that's an example of it. Or, for example, if somebody's lacking zinc or selenium, which are crucial microelements in terms of converting the storage form into the active form, if you're lacking those, you're not going to see that conversion necessary, and that will give us as well a bit of a clue in terms of the nutritional status of the patient.
So when you're looking at the blood test, that's one of the things you're looking for. What's sitting behind that? Like, why is the T3 higher, or why is the T4 higher, or what else might be this person deficient in, or system in their body not working properly?
Or even, for example, if somebody's TSH, so the brain hormone, is on the lower end, and so that means that the thyroid doesn't need that much stimulation. It's supposed to do its job perfectly. And then the person is presenting with weight gain, with low energy. We know that there is something going on in there, so you just have to look at it in a bit more detail. It's not congruent with how the patient presents. So it gives us a lot of information just looking at where are you in this normal range? Which part of the spectrum are you on?
And I know sometimes when you're on that TSH around 4 and, things sort of looking kind of just on the edge, there is I don't know, debate might not be the right word, but when do you look at medication or not? Like, do you have a view about that?
Well, so, there is the guidelines, and then there is real life, isn't it? So in terms of the guidelines, if the TSH is above 10, okay.
Above 10?
Yes, then you treat. Because of the increased mortality, pretty much, and increased risk of heart failure and cardiovascular disease. Now, the range between 4 and 10 is where you have to take other considerations into equation if you're looking at treating the patient. So, if a person's TSH is more than 4, and they, for example, already have the risk factors for cardiovascular disease or heart failure, or they have the antibodies and they're symptomatic, then you're allowed to treat them. So that's the sort of guidelines. And then you have this separate category of ladies who are trying to conceive or are pregnant, and there the official guidelines actually do say that we should be treating them in a much sort of narrower. So if the TSH is more than 2.5, for example, and especially if they have antibodies, they end up being treated with thyroxine. So that's the guidelines. And then I guess you have to sort of apply the layer of, well, how is the patient actually presenting and how are they feeling? So if somebody's TSH is above that level of 4, and they have all the classical symptoms, then you certainly have a discussion with them in terms of treatment. And in terms of somebody being on thyroxine, and you monitoring the levels, and you deciding whether they in a sort of optimal range, then you want that TSH probably not much higher than 2.5. And that's in the guidelines. So that's what we're doing.
So where the optimal ranges come into that then? Because there's a big difference between 2 and 8.
That's right. I guess, oh yes, massively, isn't it? What they're saying basically, if your TSH is above 10, even if you're not symptomatic, I would struggle to find somebody whose TSH is above 10 is not symptomatic.
Yeah, yeah, that's true.
Then you treat them. Anyway. I guess for me, the optimal range is just having that sort of alert, that little sort of red flag that what's going on in there, in terms of their nutrition, in terms of what they supply their body with, in terms of the sort of building block side of things. What else is going on? And obviously how they present, how they feel. You wouldn't necessarily start somebody who's, is not a pregnant or trying to conceive lady with a TSH of, 2.5 and no symptoms whatsoever and no antibodies. You wouldn't necessarily go that way. But you would definitely monitor and try to address the other issues, the nutritional side of things, definitely.
Yeah, so if you were on that more, I guess that's where it's individualised medicine, isn't it? It's going to depend on you and your doctor and how you feel, and hopefully your doctor understands a bit more than just, well, if it's, 4 and under, you'll be fine.
Exactly right, exactly right.
Because it seems to me that's where some of the grey area is when you're quite symptomatic but on the borderline, and do you go down the medication route or not? And maybe so would you sort of recommend maybe making some of those dietary changes and the lifestyle changes first and see if that has an impact?
Definitely, and maybe assessing for the other sort of deficiencies as well, just seeing what is your selenium, what is your zinc doing, for example. What's your vitamin D doing? That's sort of definitely... in terms of autoimmune conditions, we know that the vitamin D is sort of important massively as well. I mean, you have the protocols now for people with multiple sclerosis that include high doses of vitamin D to assist in their recovery. So those things around it that will affect your thyroid health, because it's not in a vacuum, isn't it? There's so many different things. And, you're looking at gut health, you're looking at your female hormones, for example. As females, we've got more predisposition to underactive thyroid because of our hormone, and especially when there is a hormonal imbalance. You need progesterone, for example, to help that conversion. But then maybe going back to the being assessed. So, for example, somebody is on thyroxine and they may be not feeling very well, and then they're having the levels checked, and the TSH looks okay, and the T4 is okay in a normal range. T3 maybe doesn't necessarily get checked, and that's where there is a potential problem, because on paper it can look fine, but if you're not converting that T4, which is your thyroxine that you're given, into this active form, then you can still feel just exactly how you felt before in terms of the underactive thyroid symptoms. So that's an important thing to address and look at, because often people would say, well, your thyroid is fine. It's not your thyroid. It must be something else.
So that comes back to making sure that all the tests are done, but if the TSH and the T4 looks okay, then the doctor generally won't test the T3, which could be the missing link.
Yes, and you're allowed to. If you are on the thyroxine, you are allowed to have your T3 checked.
Oh, okay. So is it just that that's not taught that you should do?
Not sure.
Yeah.
People just don't sort of see the importance of it. To see the sort of full picture.
Yeah, so I guess that's good. As a patient, if you're looking at and you're only being tested for your TSH and your T4 and they're both pretty good, but you're still feeling bad, then go to your doctor and ask to add the T3 on your next test to see if you are converting it.
Exactly right, because then you may have to look at other options. So one thing is obviously the nutritional side of things, but also another thing is, well, do you actually need the T3? on top of your T4 to be able to have all the action of the thyroid hormones into your on your basic sort of cellular level. And the T3 itself is a bit of a controversial subject because the T3 as sort of the what is available on prescription is a very short-lived hormone. So it only acts for sort of, you would have to dose it every 3-4 hours to have the benefit of it, and you would be sort of rapidly going up and down. So it's not really an answer. So you should maybe consider a slow release T3 as an addition to your T4 if you're one of those people who is not really converting the T4 to T3 and your T3 levels are still pretty low.
Yeah. So Anna, I think like what you've gone through there it is really helpful, because the reality is all of this is complex. And I've just finished reading a book called The Thyroid Debacle. It's a new book. I'm interviewing Dr. Eric Bolkavage tomorrow for the podcast. I've interviewed him before. The book is really all about how the medical system doesn't really deal with thyroid health well. And so, and it's a reasonably heavy, meaty book. And it just reinforces to me just how complex this is. And you're trying to, in a general practitioner appointment, so whether you're the doctor or you're the patient, the typical appointment's 10 minutes? So how do you possibly, even if, and you are now a very well-informed, extra qualified general practitioner with a thyroid health problem, but even with all of that, how in a 10-minute appointment do you communicate all of this to your thyroid clients? I mean, it's an impossible task.
Well, I run late.
You run late, okay. Yep.
On a regular basis, because I think that's, it's important to go through those basics, so people have understanding of what's actually going on that first appointment. So I actually sort of print out the result and I go through them with the patient because I think if somebody just rattles numbers at you without sort of showing it to you sort of black and white, it's very difficult to understand what's being said sometimes. And then you can take this home. I put little scribbles on it as well. So it's easier to go back to it. And I always say, look, get back to me, talk to me again about this. And we often recheck, especially if we, starting somebody on thyroxine, you normally would recheck the levels in 4 to 6 weeks anyway. So that's another occasion to sort of add another layer to it. But yes, I run late, I admit, because it does take time to have a proper understanding of what's going on. And there's those sort of basic things that you have to do. So as I mentioned before, testing for celiac, having somebody's ultrasound of the thyroid on, you have to have that first one just to see, because we, as a Hashimoto patients, you're more prone to nodules, for example. So just having that baseline, so we know where we are at this level, and just even assessing for things like the actual thyroid damage on that first scan. So gives us a bit of an idea of, well, how long has this process been going on? Is your thyroid little and shriveled, or is it just, maybe even enlarged and inflamed and, with all this extra blood circulating through. So it gives people a bit of an idea of, what's actually going on, so they don't feel like the body's totally just betrayed them and it's like this alien thing that it just does its own thing and we have no understanding. So I think just gives people more of an idea of what they're dealing with and what they're up against. I take my time. I do.
Yeah. Well, and I'm sure your patients appreciate that, because it's a lot to get your head around. And I think in the end, as patients, probably regardless of whatever health issue you've got, you do really have to go and do your own reading and research on top of that. You can't possibly understand. I mean, I've spent thousands of hours reading and learning about thyroid health, and I have a doctor is a holistic doctor. The appointments are 30 minutes. I mean, I pay a lot of money for it, but they're 30-minute appointments. And even in that, like that just then springboards me off to like go and do other reading and research. And, you know, it's a springboard. And so I think if you're listening, we have to be realistic about what we can expect from our medical appointments as well, even with well-informed, you know, doctors.
Well, I think for us, from my end, is just really listen, you know, and just catch those little cues that people give you, because, you know, it's all in there, and just being just that little bit extra vigilant, and so to have more awareness of, you know, could this be a thyroid condition? It does help. And, you know, I guess because of my personal experience, I feel like I am more sort of aware of it, and I'm just sort of looking out for it more than I was before.
It's good. Anyway, so Anna, if people wanted to get in touch with you or learn more from you, how can they go about doing that?
Okay, so I've just recently started a little Facebook group dedicated to lifestyle changes for Hashimoto's thyroiditis. We are tiny at the moment, but it would be great to have more people in, just sort of sharing their experiences. I will be providing a lot of, I'm hoping, value in terms of lifestyle changes that would be helpful for people. And I'm hoping that others will sort of interact and share their experience in terms of what's helpful, because there is just so much information out there, and not everything is helpful or correct. And I also, because I obviously have a limited number of hours in a day, and, you know, I'm in Western Australia, not everybody would have a chance to come and see me in a sort of face-to-face consultation. Decided to do a fairly basic sort of essential knowledge-based course in terms of lifestyle changes in Hashimoto's thyroiditis. So I've put it on a platform called mastermind.com, just sort of seeing if anybody would find it helpful. I've actually got a little promotion going on at the moment, so it's just over 30% cheaper than it normally would be. And I would say it probably is more directed at people who are maybe just starting on this journey and just looking for some clarification in terms of what is it, what is this Hashimoto's thyroiditis, and what are the simple steps I can do myself to address the symptoms and to feel better long term. So that's what I've done.
Yeah, well, I'll make sure I put the link to that, you know, in the show notes for this episode. So if you're listening and you're interested in that course and you just want to know the basics, because it is important to know the basics. And like you said, I think when we spoke initially, you know, you were talking to a client who's like, I don't even know where my thyroid is. And we have a lot of assumed knowledge. I was talking to a man a few weeks ago, a friend, and he said, do I even have a thyroid? Like, because he thought, because it is more women, you know, that have thyroid problems, he didn't even know really that he had men had thyroids. And so I think that basic information is super helpful.
I think so. And, you know, sometimes, again, you know, from like a day-to-day experience, you see people who are on thyroxine, have been on it for years, and you tell them that they've got autoimmune thyroid condition, and they just look at you and think, you know, nobody ever mentioned, there is your tablets, we can check your levels, and that's about it. There's nothing else you can do about it. So that's an interesting, and that's, you know, where I really want to, you know, help people. And this, you know, I try my absolute best on my day-to-day basis, but you know, you sort of limited as to how many people you can approach with this and change their lives in a positive way, so that they don't have to go through this alone, and have somebody to sort of help them and guide them, and definitely give them hope, because in my opinion, there's plenty you can do to address those issues and to make yourself feel.
Yeah, well, I think I will put a link to your group and to the course. so people can access that if they would like more. And obviously, if you're in Western Australia, look up Anna and go see a book in as a patient if you'd like to, if you're in Perth. So look, thank you so much. And I really appreciate your time and your expertise and just your gentle spirit and your kindness. Really appreciate that.
Thank you so much, Annabelle. It's a real pleasure. It's the first one for me, so I appreciate if I'm a bit rusty and a bit scattered brain.
Well, you are no longer a podcast virgin.
That's one to celebrate. Thank you so much for having me.
That's my pleasure.
Thank you so much for watching this episode of Let's Talk Thyroid. I would love it if you enjoyed it, if you would hit subscribe and the bell. That would be really helpful. Even more helpful actually would be to share it with someone else who you know has thyroid issues or you think would benefit from listening. That really is part of my mission, I suppose, is to spread the message of positive and practical approach to managing your thyroid health so that people really kind of have more energy to get on with living their life and not just kind of trudging through each day. So spreading that word really genuinely helps other people feel better, live better, be better. The best way that you can connect with me is through my website, which is annabellebateman.com. From there, really, you'll be able to connect in all the other ways. I would love it if you would join my Facebook community group. There's lots of great support there. It's all free. That's just being with like-minded people. But from the website, you can also book a strategy session with me. So if you're feeling a bit overwhelmed, not too sure where to start, then book a strategy session. There's also freebies to download and links to look at my online courses or purchase some essential oils or my cookbook. So that's really the hub, would be annabellebateman.com. But look forward to connecting with you and just being in this thyroid health journey together. Have a great day. Bye.
The information presented and discussed in this podcast is not intended to diagnose, treat, cure, or prevent any disease and should not be used as a substitute for proper advice from a qualified professional.